Hello, I'm Hematologist Oncologist Dr. Tony Talebi, and this lecture pertains to the Hemostasis chapter of Hematology and Transfusion Medicine Board Review Made Simple. Hemostasis involves either primary or secondary steps, primary being platelet aggregation, secondary being the coagulation. Screening involves checking prothrombin time, activated partial thromboplastin time, and platelet count. That's simple. Primary hemostasis problems, which are related to platelet disorders and von Willebrand disease, presents with mucosal bleeding, menorrhagia, and petechiae. Secondary hemostasis problems, such as coagulation protein deficiencies or inhibitors, present with hematomas, hemarthrosis, and delayed bleeding, generally speaking. Let's review the coagulation pathway. As we know, there are two major mechanisms, the fast extrinsic PT pathway and the more slow methodical PTT intrinsic pathway. So first, with any sort of trauma, tissue factor is released from the endothelial cells, which then activates factor VII. The factor VII not only activates the intrinsic pathway, but also activates the common pathway, which include 10 and 5, which then activate prothrombin to thrombin, fibrinogen to fibrin. Then the fibrin is cross-linked to the platelets via factor 13. Now the more slow methodical pathway is factor 12, 11, 9, 8, which then activate the common pathways 10 and 5. Now people always ask, which is the more important pathway? They're both important, but remember, the severe bleeders are hemophiliacs, which include factor 8 and 9. So even though the extrinsic pathway is the initial activator, the PTT pathway is a more methodical pathway, which actually drives the clot formation. Several important points. Antithrombin 3, not only does it inactivate thrombin, but also inactivates factor 10A, and that's very important when we discuss checking 10A levels. Activated protein CNS are natural anticoagulants by inactivating factor 8 and 5. The intrinsic coagulation pathway, the PTT pathway, involves high molecular weight kininogen, factors 12, 11, 9, and 8. The extrinsic coagulation pathway, the PT pathway, involves factor 7 and tissue factor. Both the intrinsic and extrinsic pathways activate the common pathways, which includes factor 10 and 5, which then activate factor 2, prothrombin to thrombin, and factor 1, fibrinogen to fibrin. Girls, remember, falsely elevated PTT may occur when blood is drawn from a central line which contains heparin. So a direct venipuncture is required in this case to exclude heparin as a cause of elevated PTT. A prolonged thrombin time, which corrects with heparin neutralizing agent Hepzyme, or a normal reptilase time, which uses snake venom not neutralized by heparin, will confirm heparin contamination. Coagulation lab tests. 1. Prothrombin time. Measures time to form fibrin clot after adding tissue factor and calcium to factors 2, 7, 9, 10, vitamin K dependent factors. Isolated elevation in PT usually reflects either vitamin K deficiency, liver insufficiency, poor nutrition, or Coumadin use, or very rarely factor 7 deficiency or inhibitor. The activated partial thromboplastin time is a two-step process that measures fibrin clot formation after adding negatively charged phospholipids in plasma. Isolated prolonged PTT can be caused by congenital factor deficiencies, acquired inhibitors, anticoagulation therapy, liver disease, and artifact. Deficiencies in factors 8, 9, 11, 12, high molecular weight kininogen can all prolong PTT. Remember, not factor 13. Also, deficiencies in high molecular weight kininogen and factor 12 can cause very elevations in the PTT but not cause bleeding. In order for the PTT to be elevated, the factor activity has to be less than 30%. This is true generally speaking, although it may vary according to which diagnostic instrument is used. Monitoring anti-10A levels, very important. You may use anti-10A levels to monitor both unfractionated heparin as well as low molecular weight heparin. The anti-10A range of 0.3 to 0.7 corresponds to a therapeutic PTT. Activated 10A is added to the test plasma, and the extent of factor 10A neutralization by antithrombin is positively correlated with heparin concentration. Monitoring of heparin with anti-10A is a preferred approach when unusually high rates of heparin infusion are required or when the patient's baseline PTT is elevated, for instance, an antiphospholipid syndrome. Low molecular weight heparins generally do not need monitoring except certain conditions such as patients who are pregnant, have very high or low weights, or have impaired renal function. In this case, plasma low molecular weight heparin activity should be checked 4 hours after injection using a chromogenic anti-10A assay calibrated against low molecular weight heparin with a therapeutic target of 0.6 to 1, so it's higher than IV unfractionated heparin. PT or PTT 50-50 mixing study used to determine if there is factor deficiency or inhibitor present. PTT or PT is repeated on a 1-to-1 mixture of a patient's plasma and pooled normal plasma, which should provide at least 50% activity of coagulation proteins. If there's factor deficiency, then the prolonged PT or PTT will correct. If there's a coagulation factor inhibitor present, then it can initially correct but will prolong again after 2 hours. If the PT or PTT does not correct, then testing for lupus anticoagulant is done, and if negative, then the patient has either a specific coagulation factor inhibitor or multiple coagulation factor deficiencies, such as liver disease. Important potential board question. If the prothrombin time does not correct with 50-50 mixing study and patient rules in for lupus anticoagulant, then most likely the coagulation inhibitor is against prothrombin factor 2, causing increased clearance, and these patients will actually be bleeders, not clotters, contrary to popular knowledge of lupus anticoagulant. Thrombin time measures time required to convert fibrinogen to fibrin clot. Remember that heparin prolongs the thrombin time. So if suspected, then check reptilase time, such as snake venom is usually not inactivated by antithrombin, so will not be affected by heparin. Hypofibrinogenemia and dysfibrinogenemia prolong thrombin time. Fibrin degradation products, FDPs, can also prolong thrombin time. That's why it's elevated in DIC. Platelet functional assay, the PFA test. The PFA test is performed with a laboratory analyzer termed the PFA 100. It uses small membranes coated with either collagen and epinephrine or collagen and ADP. Anticoagulated whole blood is passed through a membrane at high shear rate to stimulate the in vivo hemodynamics in small capillaries. Platelets adhere to the membranes and gradually occlude a small aperture in the center of each membrane. The time in seconds for the blood to completely occlude the aperture is referred to as closure time. The PFA 100 is just simply a screening test of platelet function that measures both platelet adhesion and aggregation, primary hemostasis. It may be used for the following: evaluating a bleeding patient, evaluating the presence of a suspected drug-induced platelet dysfunction, or determining patient compliance with aspirin and other antiplatelet drugs. However, the PFA 100 test is dependent on platelet function, plasma 1 milligram factor levels, platelet number, and to some extent the hematocrit. So it's a very sensitive test. The PFA test is initially performed with collagen epinephrine membrane. A normal collagen epinephrine closure time excludes the presence of a significant platelet function defect. If the collagen epi closure time is prolonged, then the collagen ADP test is automatically performed. If the collagen ADP test is normal, then aspirin-induced platelet dysfunction is likely. The PFA test results are usually not valid if the patient has either anemia, thrombocytopenia, or a significant platelet function defect other than aspirin. Once anemia and thrombocytopenia have been excluded, Further evaluation to exclude von Willebrand disease and inherited acquired platelet dysfunction, such as renal failure, storage bowl disease, release defect, Bernard-Soulier, Glanzmann's should be considered. Platelet aggregation test. In this technique called light transmission aggregometry, LTA, blood is centrifuged at sufficiently low force to obtain platelet-rich plasma, PRP, which is stirred in a curate at 37 degrees centigrade between a light source and a measuring photocell. Upon addition of an agonist such as ADP, the platelets aggregate. The resultant increased transmission of light, for instance reduced turbicity of the PRP, is detected and recorded as a function of time after addition of the reagent. These changes reflect the formation of a relatively large platelet aggregates, which are in turn derived from microaggregates. Platelet aggregates, ADP, collagen, arachidonic acid, epinephrine, or risocetin. So remember these. The agonists, again, are ADP, collagen, arachidonic acid, which is very important for aspirin, epinephrine, and risocetin. Platelets, this is the most important part. The most important thing to remember about platelet aggregation tests: patient should not be taking any medicines for 1 or 2 weeks before testing, since a variety of medicines will interfere with the test results, including antihistamines, aspirin, antidepressants, caffeine, alcohol, anticoagulants, cardiovascular agents, and sedatives. All of these may affect the result. If you remember anything from this lecture, please remember this, because as you know, our surgical colleagues love to obtain platelet aggregation tests, and they're often abnormal, secondary to patient having taken medicines. If the aggregation test is abnormal, repeat the test first. And remember, the most common cause is medicines, not underlying abnormal platelet function test. So, platelet aggregation assays. The aggregation assays are the primary ADP, which is adenosine diphosphate, secondary ADP release, collagen, and risocetin. Important to know that in Bernard-Soulier, the aggregation to risocetin will be abnormal, whereas in Glanzmann's, aggregation to all others will be abnormal except risocetin. With NSAIDs and aspirin, both the secondary ADP and collagen will be low, but primarily the defect will be to arachidonic acid. Again, very important. Aspirin effect may be tested using arachidonic acid as the agonist. Results will show absent aggregation response to arachidonic acid, as well as reduced secondary aggregation to ADP. So, 3 very important examples. Number 1, 35-year-old female with heavy menses, platelet count normal, PFA 100 to collagen epi prolonged, but collagen ADP normal. Platelet aggregation, absent arachidonic acid. Diagnosis, aspirin effect. Second case, a 16-year-old female with heavy menses, platelet count normal, platelets large. Remember large, keyword. PFA 100 to Cali epi and collagen ADP both prolonged. When you see both are prolonged, there is a serious problem. Platelet aggregation, absence of risocetin. Diagnosis, Bernard-Soulier. So, if you see large platelets, absence of aggregation of risocetin, that's Bernard-Soulier. Next case, 16-year-old female with heavy menses, platelet count normal in size, PFA 100 Cali epi and Cali ADP both abnormal. Platelet aggregation, normal to risocetin, decreased to all others. Diagnosis, Glanzmann's. Von Willebrand factor assays. Endothelial cells and megakaryocytes synthesize von Willebrand factor. Type O blood individuals have 25% lower von Willebrand factor than non-type O patients. Also, very important, pregnancy and menstrual cycle may alter von Willebrand levels due to estrogen levels. The most widely used method to assess von Willebrand factor binding to platelets is the risocetin cofactor assay, performed on platelet aggregometry. Risocetin is an antibiotic which causes significant thrombocytopenia. That is why it was never used on patients, by potentiating platelet binding to von Willebrand factor. The alpha-2 antiplasmin assay, useful in extended workup of suspected bleeding disorder in a patient with normal PT, PTT, and platelet count. Lupus anticoagulant test, phospholipid-dependent assays such as PTT with low phospholipid content and the dilute Russell's biproverdin, again very low phospholipid content, which makes them even more sensitive to antiphospholipid antibodies. They're all prolonged by lupus anticoagulant. The clot stability, factor 13 assay, measures the stability of clot in the presence of denaturing conditions. If fibrin has been appropriately cross-linked, then it should resist denaturing agents. So dissolution of clot less than 24 hours by 5 molar urea suggests presence of factor 13 deficiency, since the clot had not been properly cross-linked. Bleeding disorders. Elevated PT and PTT. Case report. 9-month-old male developed swelling of the right thigh following minor trauma. Patient with elevated PT and PTT, but normal platelet count and thrombin time. CT scan reveals a thigh hematoma. PT and PTT do not correct with vitamin K administration. Factors, so if you have elevation in PT, PTT, then obviously you need to check the common pathway. So factors 5, 2, and 1 are normal, but factor 10 activity is low, only 10%. So patients with elevation of both PT and PTT think common pathway problem. So check factor 5, 10, 2, and 1. Hypofibrinogenemia, dysfibrinogenemia, DIC, and lupus anticoagulant may cause this as well. Von Willebrand disease. There are 3 major subtypes, type 1, type 2, and type 3. And type 2 is further broken down to type 2A, B, M, and N. Testing for von Willebrand disease. The core tests are the von Willebrand activity, the antigen, factor 8 activity, von Willebrand multimers, and also RIPA, risocetin-induced platelet aggregation, as part of type 2B workup, and platelet count. Type 1 von Willebrand disease case report. 15-year-old female presenting with excessive bleeding after tonsillectomy, PT normal, PTT elevated, that's due to low factor 8 levels, platelet count normal, von Willebrand antigen low, but the activity normal. The activity, again, is a correlation of von Willebrand factor binding to platelet 1B receptor. Multimer is normal. RIPA normal. So again, if you see low antigen but normal activity, that's type 1. It's the most common inherited bleeding disorder, affecting up to 1% of the population, autosomal dominant. Actually, many women that have heavy menses typically have some degree of undiagnosed type 1 von Willebrand possible. Von Willebrand factor circulates as a series of multimers formed from a basic dimer subunit, providing multiple binding sites that can interact with both platelet receptors and subendothelial structures at the site of injury. Type 1 von Willebrand disease decreased platelet-dependent function that is not associated with loss of high molecular weight von Willebrand multimers. Type 2A case report. 15-year-old female with excessive bleeding after tonsillectomy. Normal PT, elevated PTT, again due to low factor 8 levels. Decreased von Willebrand antigen, but even lower von Willebrand risocetin activity. And there's absence of large multimers. So very simple. If you see low activity, if you see low antigen, but even lower activity and complete absence of multimers, that's type 2A. Type 2B, case report. 15-year-old female, with excessive bleeding after tonsillectomy, normal PT, elevated PTT, decrease von Willebrand resistant activity and antigen, decrease large multimers, but the most important, increased RIPA and decreased platelets. So if you see slightly low platelet count as the clearance is increased by the gain of function of von Willebrand protein by binding excessive platelets, if you see increased RIPA, slightly low platelets, that's going to be type 2B. Remember, never administer type 2B patients DDAVP, as it will cause worsening thrombocytopenia, as the von Willebrand will bind even more platelets. Type 2M, case report. 15-year-old female presenting with excessive bleeding after tonsillectomy, normal PT, elevated PTT, decreased antigen, but pronounced decrease in von Willebrand activity, and normal multimers. So remember, type 2M will have decrease in antigen, even lower activity, but normal multimers. And type 2A will have decrease antigen, even lower activity, and absence of multimers. So that's how you differentiate 2A versus 2M. Type 2N is a Normandy. 15-year-old, this is a take-home, 15-year-old female. If you see the exact same case presentation with a male, it'll be hemophilia A. If you see this case presentation with a female, it'll be type 2N. 15-year-old female presenting with excessive bleeding after tonsillectomy, normal PT, elevated PTT, normal von Willebrand antigen activity, normal von Willebrand large multimers, but very low factor VIII level, normal RIPA. So it looks exactly like hemophilia A. This is due to the von Willebrand protein having very low affinity for factor VIII, and therefore it does not bind and protect it. So again, on the boards, if you see a female with elevated PTT and bleeding disorder, think von Willebrand type 2N. If you see a male with the same issue, think hemophilia. Very rarely, females may also be hemophiliacs if there's lionization of one X chromosome, but for the board, it will be very unlikely for you to be presented that case. So for type 2N, perform binding assay for von Willebrand factor binding affinity to normal factor VIII, and it'll be low in type 2N. Type 3, von Willebrand disease. Case report. 15-year-old female with excessive bleeding after tonsillectomy. Normal PT, elevated PTT, extremely low antigen, and extremely low activity, and complete absence of multimers. That's type 3. So again, in review, type 1 deficiency, quantity is low, but quality is normal. And type 2, quantity is low, but the quality is even lower. And in type 3, both quality and quantity are very low. Notable exceptions in type 2B, the platelets have very high affinity for von Willebrand factor, so their RIPA will be elevated and patient will be slightly thrombocytopenic. In type 2N, it'll be a female, not a male, presenting with bleeding and factor VIII deficiency. The factor VIII here is due to decreased von Willebrand factor binding affinity for factor VIII. Treatment consists of DDAVP, desmopressin, 0.3 micrograms per kg intranasally or IV. This stimulates release of von Willebrand factor and factor VIII from endothelial cells. But you need to watch out for SIADH and tachyphylaxis. And do not use in type 2B, as it will cause worsening von Willebrand factor multimers binding to platelets and hence worsening thrombocytopenia. Also, do not use in type 3 since there's no von Willebrand factor available to be released from the endothelial cells anyhow. You may also use Humate P, which contains von Willebrand factor and factor VIII or alphanate. Goal is to maintain von Willebrand factor and factor VIII levels between 50 and 100% with severe bleeds. May use Humate P in type 2B or 3. Also may use aminocaproic acid or recombinant factor 7. Inhibitor to factor 5, case report. 47-year-old man who has undergone cardiothoracic surgery in which fibrin glue was used to control bleeding. Following surgery, presents with elevated PT and PTT, which is not correct with 50-50 mixing study. Negative antiphospholipid workup. Fibrin glue contains bovine factor V, which causes alloantibody production, which then cross-reacts with cell factor V antigen. Now, recombinant fibrin glue is used, which does not cause alloantibody production. Hemophilia A and B, congenital factor VIII or IX deficiency. Case report, 22-year-old male presenting with hemarthrosis. Said multiple family members with bleeding disorder as well. PT normal, PTT elevated, corrects with 50-50 mixing study. Platelet count normal. Hemophilia A, factor VIII deficiency, or B, factor IX deficiency are X-linked recessive diseases. Can diagnose via RFLP, restriction fragment-like polymorphism, or other molecular methods if you know the mutation of the family. You may look for the same single nucleotide polymorphism, so very important, often asked about on the boards. If you suspect hemophilia, then you use RFLP to detect the same region in family members afflicted with the disease, and you compare it to that individual patient. Disease ranges from severe, less than 1% factor activity, to moderate, between 1 and 5% activity, to mild, more than 5% activity. Affects males only. Females are carriers unless there is lionization and activation of one X chromosome, which will make the female symptomatic as well. Most common bleeding sites are into joints, muscles, and the GI tract. Treatment for factor VIII for hemophilia A. The intermediate purity is a humate P, and that has transmitted HIV and hepatitis B and C in the past. It's actually what wiped out most of the hemophiliac population in the 1980s. Now, the recombinant factor VIII, first generation, called recombinant, that contains albumin, which theoretically may transmit infections as well. Third generation, called Advate, does not contain albumin. Factor IX for hemophilia B. Eventually, the patient may develop inhibitor to factors VIII or IX, which necessitates use of bypassing agents, such as either factor VII or FIBA. For minor surgeries, keep factor VIII or IX levels between 50% for 3 to 5 days. For major surgeries, keep factor VIII or IX above 80% for 10 to 14 days. Inhibitor development in hemophiliacs. Case report. 6-year-old boy, known hemophiliac with factor VIII level 8%, diagnosed at the age of 6 months. Presents with a 2-day history of continuous bleeding post-tooth extraction. He's immediately given factor VIII concentrate, 20 units per kg IV stat. A hemostat sponge with transamine pack is given to the area by the dentist with an advice to continue management. He's admitted in the evening, and in view of continued bleeding, another dose of factor VIII is given. However, the next morning the patient continues to bleed and the PTT continues to be elevated. Therefore, inhibitor development investigation is done, and the Bethesda inhibitor titer is more than 10. Hemophiliacs may develop inhibitor antibodies to either factor VIII or factor IX transfusions. The Bethesda assay determines the potency of factor VIII or factor IX inhibitor by incubating dilutions of the patient's plasma combined 1-to-1 with normal plasma at 37 degrees Celsius for 2 hours, followed by determination of residual factor activity. The antibody titer is expressed in Bethesda units equal to the reciprocal of the patient's plasma dilution required to obtain recovery of 50% of the expected factor VIII activity. If the Bethesda inhibitor titer is low, less than 5, then may administer higher doses of factor VIII or factor IX. If the Bethesda inhibitor titer is high, more than 5, then we'll need to use bypassing agents such as recombinant factor VII or FIBA until the Bethesda unit of the inhibitor decreases to less than 10. Once the Bethesda inhibitor titer is less than 10, then may consider long-term option to utilize immune tolerance therapy. It means low-dose exposure of the factor to prevent immune response. The dose is either 200 units per kg daily or 50 units 3 times per week. Factor 11 deficiency, seen in Ashkenazi Jews with elevated PTT and slow oozing following minor surgery on mucous membranes such as GE or ENT, rather than a brisk bleed, and is autosomal recessive. Bleeding risk is unpredictable, and some patients are asymptomatic despite low factor 11 levels. Treatment, FFP, as needed. Factor 12 deficiency, case report. 50-year-old female with no previous bleeding issues despite multiple surgeries and very elevated PTT, which corrects with 50-50 mixing study. Workup reveals factor 12 of only 15%. Side note, remember, factor 13 deficiency does not cause elevation of PTT. Back to factor 12 deficiency, it's not associated with bleeding, even if it causes elevation of PTT, so may proceed directly to surgery. Now, factor 13 deficiency. Think of it when a newborn infant presents with delayed umbilical cord stump bleeding. Patient will have a normal PT, normal PTT and platelet count, and the urea clot lysis time will be less than 24 hours. Think factor 13 cross-links fiber monomers to produce a durable clot. Factor 13 screening test is based on the time it takes for a clot formed in the presence of factor 13 to dissolve after 5 molar urea, called the urea clot lysis time. If the clot dissolves within the first 24 hours, it is considered abnormal and indicates factor 13 deficiency. Remember, normally it should take more than 24 hours for the clot to dissolve in the presence of 5 molar urea. Acquired von Willebrand factor deficiency. Case report. 35-year-old woman affected with essential thrombocytosis presenting with epistaxis. Normal PT and PTT, platelet count over 1 million. Profile of plasma von Willebrand factor reveals decreased cofactor activity and diminished large multimers in spite of normal antigen levels. There's no evidence of circulating inhibitor against factor VIII complex. The von Willebrand factor abnormality improves by controlling the platelet count following treatment of essential thrombocytosis with Hydrea. So, the acquired von Willebrand factor deficiency is seen in essential thrombocytosis and other myeloproliferative diseases in which platelets bind to and clear large von Willebrand factor multimers, leading to acquired type 2 von Willebrand disease. Seen when platelets are between 1 million and 2 million. Treatment corrects with lowering platelet count. Prenatal diagnosis of factor VIII deficiency. Hemophilia A is genetically heterogeneous disease. 70% have an inversion mutation that is detected by southern blot analysis. Prenatal diagnosis is facilitated by knowledge of factor VIII abnormalities seen in other family members, via RFLP for instance. If clinically indicated, immediate postnatal testing may be helpful. Acquired factor VIII inhibitor case report. 56-year-old female presenting with ongoing GI bleeding, which does not correct with EGD and cauterization of the gastric ulcer. Patient has normal PT, normal platelet count, elevated PTT, which does not correct with 50-50 mixing study, and a negative lupus anticoagulant workup. Measured factor VIII activity is 5%. PTT measured last year was normal. Always suspect in an elderly patient who has elevated PTT that does not correct with 50-50 mixing study. Seen in patients with cancer or autoimmune disease. The Bethesda assay determines the potency of factor VIII inhibitor by incubating dilutions of patient's plasma combined 1-to-1 with normal plasma at 37 degrees Celsius for 2 hours, followed by determination of residual factor VIII activity. The antibody titer is expressed in Bethesda units equal to the reciprocal of the patient's plasma dilution required to obtain recovery of 50% of the expected factor VIII activity. A Bethesda unit of 0.5 to 5 is a low titer, whereas Bethesda unit more than 10 is considered a high titer of the inhibitor. Low Bethesda unit can be overcome with infusion of factor VIII, whereas high titers require bypassing agents such as recombinant factor VII or FIBA. Treatment: immune suppression with steroids or cyclophosphamide, rituximab, recombinant factor VII, FIBA, or treat the underlying etiology, including the cancer or autoimmune disease. Congenital hyperfibrinolysis. Case report. Term infant born without complications but has increased oozing from heel stick. PT, PTT, platelet count, fibrinogen, all normal. Negative family history and screening for factor 13 deficiency. The euglobin clot lysis time is very short, less than 15 minutes. So if every workup is negative, check the euglobin clot lysis time. Think about congenital hyperfibrinolysis in severely bleeding patient with normal PT, PTT, fibrinogen, and platelet count. Congenital hyperfibrinolysis describes a situation with markedly enhanced fibrinolytic activity, resulting in increase and sometimes catastrophic bleeding. Once a thrombin clot is formed, it stimulates the secretion of tissue plasminogen activator TPA by the vascular endothelial cells. Plasminogen and TPA assemble on the fibrin to generate plasmin, which breaks down the clot from fibrin to fibrin degradation products. So a review of how a clot is broken down. Once a clot is formed, the tissue plasminogen activator activates plasminogen to plasmin, and then the plasmin breaks the fibrin to FDPs. Now, alpha to antiplasmin prevents conversion of plasminogen to plasmin, so that prevents clot degradation. And the plasminogen activator inhibitor 1 and 2 prevent the activation of TPA, so they also prevent clot breakdown. So anything that inhibits alpha-2 antiplasmin or plasminogen activator inhibitor will then drive clot breakdown. So hyperfibrinolysis occurs due to a deficiency of alpha-2 antiplasmin or plasminogen activator inhibitor. So the TPA and plasmin are in hyperdrive and continue to break down the clots. Now the bleeding is caused by the generation of FTPs, which interfere with regular fibrin polymerization and inhibit platelet aggregation. This is a very important concept to know. In order to have an elevated D-dimer, there has to have been fibrogen that has been converted to fibrin, and then the clot proteolyzed by plasmin. So a clot must have been formed for there to be elevated D-dimer. Whereas elevated FDP is the breaking down of fibrinogen before it has been converted to fibrin and it formed clot. So elevated FDP can occur in settings where there has not been a clot that has been formed yet. So for congenital hyperfibrinolysis, check plasminogen activator inhibitor, activity and antigen, TPA antigen, and alpha-2 antiplasmin activity. The diagnosis of hyperfibrinolysis is made indirectly with immunochemical methods which detect the elevation of D-dimer, cross-linked fibrin degradation products, and fibrin split products, and complexes of plasmin and alpha-2 antiplasmin. The euglobin clot lysis time will be shortened. Treatment is Amicard. Now, acquired hyperfibrinolysis. 40-year-old man with cirrhosis and increased diffuse oozing despite correction of elevated PT, PTT, and with FFP. Patient has low fibrinogen, elevated FTPs, and shortened euglobin clot lysis time. This reminds me of when I was a resident at USC, in which the ICU was full of very young males with severe alcoholism and cirrhosis who were all in acquired hyperfibrinolysis. The increased circulating plasmin from decreased hepatic clearance and cirrhosis overwhelms alpha-2 antiplasmin levels, which leads to increased TPA and hence clot breakdown. In DIC, the increased FTPs interfere with regular fibrin polymerization and inhibit platelet aggregation as well, leading to bleeding. So the treatment of acquired hyperfibrinolysis is aminocaproic acid, which reverses the clot breakdown. Vitamin K deficiency in an infant. A term infant born to an uncomplicated pregnancy, mother breastfeeds and refuses vitamin K injection prior to infant's discharge. Patient presents 1 week later with intracranial hemorrhage, elevated PT and PTT. What happened? Breastfeeding can cause vitamin K deficiency. Treatment, vitamin K. Immune thrombocytopenia, ITP in children. Case report. A 6-year-old female presenting with petechiae, had an upper respiratory tract infection 3 weeks ago. Has normal WBC and hemoglobin, but platelet count of 16,000. Normal PT, PTT, and peripheral smear reveals decreased platelets and no schistocytes, so not a DIC. Pediatric hematologists use a threshold platelet count of 10,000 to treat ITP in children. Platelet count is above 10,000, then reassure and follow. If it's less than 10,000, then treat with IVIG and steroids. HIV-induced ITP, case report. 45-year-old man with HIV and low CD4 counts, less than 200, not on heart therapy, presenting with petechiae, purpura, epistaxis, and platelet count of 14,000. Bone marrow biopsy, although not needed, reveals increased megakaryocytes. HIV virus causes decreased production of platelets by infected megakaryocytes, in addition to increased peripheral destruction from increased antibody formation due to HIV virus infection. So begin heart therapy, highly active antiviral therapy, and platelets should improve within 1 or 2 months as the viral load decreases. The transfused platelets also have a very short lifespan on ITP, so of little benefit. Glanzmann's thrombasthenia, case report. 6-month-old infant presents with several month history of easy bruising and oozing from a heel stick. Patient has normal PT, PTT, fibrinogen, platelet count, 1 milligram screen, factor 13, and key point, platelet size normal. Causes deficiency of platelet 2B3A, which may diagnose with flow cytometry. Platelets are normal in size. Platelet aggregation only aggregates normally to ristocetin, the opposite of Bernard-Soulier, which aggregates to ADP and collagen but not ristocetin. Treatment, platelet transfusions, and recombinant factor 7 in patient bleeding. Bernard-Soulier, case report. 4-month-old infant presents with several month history of easy bruising and oozing from a heel stick. Patient has normal PT, PTT, fibrinogen, platelet count, 1 milligram screen, factor 13, and platelet size is enlarged, keyword. Due to deficiency of platelet GP1B receptor, which may be diagnosed via flow, platelet size are large in size, and then platelet aggregation aggregates normally to ADP and collagen, but not ristocetin. Treatment, platelet transfusions, and recombinant factor 7 in patient bleeding. This concludes the hemostasis chapter. Thank you.